Millions of patients are dying all around the globe, and the death could be either prevented or treated if we were using the results of research. Now, as a physician, you can only be up to date if you understand and critically evaluate research results. And it's not enough to understand what's written in the articles, but you have to implement that and apply that at the bedside. And to do that, you have to be critical with what you read, and you have to understand it in a critical manner. So if you are interested in that, then please join me for this lecture, which will take about 15 minutes. And the title was given to me by Zoli, so I tried the best to make out of it. Let's just spend a couple of minutes on evidence-based medicine, its evolution. Before 2000, the slides are the courtesy of our good friend Peter Hegyi, by the way. So before 2000, there was the feature of medical profession was something like that there were big professors all around the globe, and depending on the size of the hospitals, they saw a certain number of patients, a certain spectrum of the patients. And more or less, they had different ideas, they taught differently, and the treatments also depended on their personal preference. So the poor residents, they had to learn who likes what, okay? And regarding the patients, well, those patients who were outside of the scope of that certain department or unit or hospital, they were unlucky, they might not get the right treatment, but fortunately many patients were within the scope of these great professors and they received appropriate treatment. So the residents had to learn what the professor wanted, and unfortunately, this is where we still are in Eastern Europe. And if you don't believe, if you think I'm wrong, then come to or visit the Hungarian specialist exam in anesthesiology and intensive care and ask the candidates if they do the exam in one city, they know what to learn, in other city there's something else to learn. So we are still 25 years behind. Because what happened in medicine after 2000? Well, these big professors made a paradigm shift, and they decided to unite forces and to do multi-center randomized controlled trials in order to generate evidence. So from then on, they tried to think in a similar manner, teach in a similar manner, and they also treated the patients according to international guidelines. So the residents, not here in Hungary, but around the world, they had to learn the guidelines, the current treatment strategies. So as the patients benefit, of course, more and more patients now are receiving guideline-based treatment. So up-to-date medicine without appliance science is impossible, because the number of publications, that I will get back to this at the end of my talk, is just enormous. Now, how to translate this knowledge, and you have seen several examples of what we've been doing here at the Center of Translational Medicine over these last 2 days, and I also brought some results of ours here with you, and I will try to criticize them as well. But this one is there will be positive and negative critics, of course. So this one is a positive trial. We did that, one of the first and one of the highest cited meta-analysis of ours. And that was, the research question was whether local anesthesia helps the recovery of patients after undergoing bariatric surgery. And the topic of the intervention was that the transabdominal plane block. And what we found when we compared patients with or without transabdominal plane block, we identified all randomized controlled trials, and we observed regarding the pain score a significant more than 2-point reduction in that group, regardless whether it was just 1 hour after surgery, and there was even a positive signal at the end of after 24 hours of surgery. So there is better pain relieving effect if you use transabdominal pain block. Morphine consumption was also significantly reduced in that group by almost 8 milligrams over 24 hours. And these patients were able to be ambulated, to get out of bed more than 2 hours faster than in the other group. And the reason why I'm showing you this, because this meta-analysis eventually got us into the current era's guideline that was written about bariatric surgery. You can read it there. The reference is ours, and based on that, the recommendation gives a strong recommendation with high level of evidence to use local anesthesia for that type of surgery. You listened to the presentation of Chenge yesterday when we investigated. Basically, it was Zoli's idea to carry on. We did a study with Zoli on intraoperative PEEP titration, and this just a meta-analysis investigating this topic in general. So you saw that in those patients in whom the physicians performed individualized PEEP titration, patients received 6 centimeters of water higher PEEP on average, and that resulted in significant improvement in oxygenation. And this improvement in oxygenation most likely contributed to the fact that these patients had 50% less pulmonary postoperative pulmonary complications as compared to the control group. So the message of this, that if you are unhappy in the operating room with the saturation of the patient or with the high FiO2 then you have to use, then please play with your PEEP level on that patient. And this is a negative example. Janner hasn't shown you this meta-analysis, one of his other article. In this week, the research question was whether hemoadsorption therapy for critical patients with acute liver dysfunction has any benefit or not. And we observed a massive benefit, because if you treat these patients with hemoadsorption, their bilirubin level was significantly reduced by 4.8 milligram per deciliter. And if you look at the SOFA score, which scores liver dysfunction, this kind of degree of change jumps the patient from 2 degrees in the liver dysfunction score. So this is not just statistically significant, but clinically extremely relevant. However, when you read the articles we actually included in the meta-analysis, they all come from, most of them, 3 out of the 4, come from one center, from Bucharest. And there might be some overlap in the population. It was difficult to trace. So we have to take it with a pinch of salt. So when you see something like that, you have to interpret the results with some caution. Now, the Surviving Sepsis Campaign guideline, because I quoted that nowadays we try to treat our patients according to guidelines. It says that we should give 30 milliliter per kilo intravenous crystalloid within 3 hours to our patients with septic shock. Although the recommendation is low, is a weak recommendation, just 1 exclamation mark, and the evidence is also low that supports that treatment, but nevertheless, this is still in the guideline. And I've seen many patients receiving that in the Hungarian accident and emergency units. The big 5, one of them is give 30 milliliter per kilo of crystalloid. So the next research question we had, this is Gábor Nagy, who we are performing this meta-analysis, whether this strategy has any effect on 30-day mortality as compared to personalized administration of fluid. And we observed a very strong, significant difference. In fact, almost 40% less likely that these patients are going to die who receive personalized fluid administration as compared to fixed volume. So we do hope that we will publish that soon, and this will kind of be another strong argument against and change the guideline and remove this statement from the guideline. Regarding when you look at the article, how to interpret the data itself. This is a Bach trial investigating the diagnostic accuracy of clinical signs and procalcitonin and other biomarkers. And I just want to draw your attention to this part of the results, that these are patients coming to the hospital with chest complaints. And then You don't know whether they have infection or not at the moment. Now, in a post hoc analysis, it turned out that there were 1,500 patients who had no infection, but 150 patients had infection. Now, when you look at the clinical picture, there is a strong difference. Heart rate, blood pressure, temperature, pulse oximetry. Everything is significantly worse in patients who have infection. But when you look at the data, if you look, you don't just look at the significance level, but look at the data. Heart rate of 90 and 100, blood pressure diastolic 80 to 75, and temperature 37 to 37 basically, and the pulse saturation is again 95 and 93. So basically, statistically significant results, but clinically completely irrelevant. You cannot use. So whenever you read an article, please look at the results. Going back to my favorite thing, the Surviving Sepsis Campaign guideline, they suggest against using procalcitonin plus clinical picture. The recommendation is again weak, and the evidence is very weak. Now, when you look at the actual trials they refer to, there are 3 large randomized controlled multi-center trials. However, 40% of the patient population of that trial was surgical patients. And with Tamás, actually, 25 years ago, we've shown that in surgical patients, after major surgery, the PCT goes up to a median of 2 to 4. So in these protocols, the intervention cutoff was 0.5 nanogram per milliliter procalcitonin. So in 40% of the population of these trials, it was coded that they will get antibiotics. So going back again to the Surviving Sepsis Campaign guideline, it recommends you to give immediately within 1 hour antibiotics to the patients. And on several presentations on this meeting, I saw that when you wrote sepsis, the first thing to do is give antibiotics and then organ support. No, guys, it should be completely the other way around. The number 1 treatment is organ support. And then you can think about antibiotics. Why? Because although the recommendation is strong, but the level of evidence is low. So this is basically just, it's not proven, not at all, that you have to give antibiotics so fast. But because the recommendation is strong, a consequence is unnecessary antibiotics therapy all over. So the solution we are providing, and Janer already depicted this meta-analysis that we did with Marci, that if you use procalcitonin-guided algorithms to treat your patients, then you can reduce the length of antibiotic therapy, and you may also increase mortality. We found a significant positive signal there. And to prove our PCT-guided concept, the Kiprun trial, now approved by our ethics board, it's in the process of being published on clinicaltrials.gov, and we hope that after training we will start the trial in November. Going back to meta-analysis, on this meeting we heard a lot about how to behave on the ICU, how to take care of our patients and relatives. And it has evidence that you should allow relatives in the ICU all around the clock. This is a meta-analysis which clearly indicates with a lot of patients, 3,000 patients, and it indicates that there is a 60% mean reduction in the incidence of delirium if you allow patients to the ICU versus restricted visiting hours. And it may also reduce, here, that was a strong significant signal, the ICU stay. And that was also mentioned here before, that 1 day of ICU stay has a serious impact on the long-term quality of life of our patients. So a reverse critical eye, because now you read this and you have to critically evaluate your practice at home. Am I doing the best for my patient in the mirror of that? Something to think about. And finally, is this critical eye really so important? Well, let me take you back to COVID-19. Again, we cited COVID several times on this meeting. That was an unprecedented period. There were times that 250 papers per day were published with COVID-19 in the title. Now, we've been doing meta-analysis for several years now, and we found something like, if you have 30 articles, oh God, it's going to take 2 years to analyze the data kind of thing. 250 papers per day. And this is a lovely paper, Nature Reviews. They looked into these publications which investigated the effects of drugs on COVID, okay? And regardless of the results, but this is fantastic. They found that 95% of the published articles were rubbish. They did not fulfill the criteria of good clinical research at all. So only 5% was used. So we need a change of paradigm, at least here in Eastern Europe, from several extents, and we have to put clinical experience and the scientific knowledge into context. And this is a great paper. You have quoted that before on this meeting, the individualizing resuscitation. And at the very end of the paper, Jean-Louis and co-workers quote this article from Dr. Sackett, who published that. That was the first, or the milestone of evidence-based medicine in 1996. And Dr. Sackett and colleagues clearly indicate that individual clinical expertise is very important, but just as well, we need the best clinical evidence. If you neglect one or the other, that you will be either tyrannized by the evidence or become out of date very, very quickly. So we have to find a balance, as this yin-yang has shown to us. And with this, thank you for your attention.